I hope you can hear me. First of all, welcome to this lecture in Rashid Medical College. The lecture is about heavy menstrual bleeding. I must thank you for coming online and listening to me because for the teacher or lecturer, it's always very encouraging when a large number of students turn up to listen to him. But even if a few of you turn up, my passion is to give lectures, so I won't mind at all. I'll continue talking. And in view of the present situation in Pakistan and the subcontinent, this is not the best times, not only because of COVID infection, it is destroying the economy of the countries and also social well-being of people and raising a lot of anxiety when they are isolated or closed doors. But still, we must continue education because colleges and schools are closed and people at home, not all the students are continuing their home studies. Some of them do, others don't. I strongly recommend, even if you're at home, your college or school is closed, you should continue to read your textbooks. Or if you have opportunity to listen to the lectures online, do that. Because those who continue their education, they will take the lead when they become doctors. Those who do not, they will be left behind because of lack of knowledge. So I very strongly recommend to all of you, whenever opportunity, not only my lecture, whenever the opportunity is there, listen to the lectures, even if you're confined to your homes. The topic of the day, heavy menstrual bleeding. This is relatively new nomenclature, heavy menstrual bleeding, because the old terminologies for this kind of bleeding were menorrhagia, dysfunctional uterine bleeding, metrorrhagia, abnormal uterine bleeding. All these terminologies were used. But now this kind of composite, complete, that heavy menstrual bleeding, irrespective of its cycle, its amount, its duration, that perhaps covers all these terminologies which were previously used. Before we start talking about heavy menstrual bleeding, let's learn something about normal menstrual bleeding. We all know menstrual cycle starts at menarche and finishes at menopause. And during these, what we call them reproductive years, menstrual cycle is regular, 28 plus minus 7 days. So any woman who menstruates for 28 days, that's normal cycle, duration of the cycle. But the one who bleeds after 3 weeks, that is 21 days, or after 5 weeks, even they are normal. So it's important to understand that if the cycle is shortened or prolonged by 1 week, then we take it as normal variation. You need not treat that variation because falls within physiological limits. Normally, when bleeding takes place or menstruation takes place, the bleeding is there for 2 to 8 days. More likely 4 to 5 days is the average. But any woman who comes to you and complains that she bleeds only for 2 days, you can reassure her that it is within normal limits. On the other side, if another patient comes to you and complains of bleeding for 8 days or 7 or 8 days, that is also within normal limits. So there's no need to treat these patients who are bleeding only for 2 days or prolonged for 8 days because the average is 4 to 5 days. So they still fall within normal limits. And the total amount of bleeding over those days, if we accumulate, if we calculate the total loss, it varies from 10 to 80 milliliters. So there are patients who come and say the bleeding is very small, scanty, and if it is up to 10 milliliter, it is normal. And the one who comes to you and complains she has to change many sanitary pads, the bleeding is nearly 80 milliliter. We don't have easy way of working out whether it is 80 or 10 or 40 or 50. But generally speaking, you ask a patient how much she used to bleed when she thought she was normal. If she says, I used to change 4 or 5 sanitary pads, now it is 6 or 7, I would say it is close to her previous normal. But if it was 4 to 5 sanitary pads, now it is more than, say, 10 pads, or there are clots on the pad, then that is abnormal. So remember, the normal duration of the cycle is 28 plus minus 7 days. Duration of bleeding is 2 to 8 days, and amount is maximum up to 80 milliliters. Oh, we've gone back. Well, when there is abnormal bleeding, that means that either the amount of bleeding will increase or duration of bleeding, the days for which the patient bleeds, they will increase. Instead of 2 to 8 days, maybe 10 days, 12 days, the duration will increase. And the other possibilities are that menstrual cycle may become regular or irregular. Even if the regular cycle but bleeding in amount or duration is there, we'll call it heavy menstrual bleeding. On the other hand, if the cycle is also disturbed, abnormal, then and the amount is more, we call that also heavy menstrual bleeding. So the amount of bleeding, when it is more than 100 milliliters, our duration of bleeding is more than 10 days. This patient comes under the category of heavy menstrual bleeding. Let's learn first the causes of heavy menstrual bleeding. Heavy menstrual bleeding is not due to one cause. We can't say, as you say, malaria is because of malaria parasite, one cause. But here, there are multiple causes and multiple variety of heavy menstrual bleeding or types of heavy bleeding. And as there are multiple, so the problem has to be found, that we find out what is the cause. Most commonly, without a local cause. When a patient comes to you with heavy menstrual bleeding, you examine her or you get her ultrasound done, then the uterus and ovaries are anatomically normal in most of those patients. So common type of heavy menstrual bleeding is with the uterus and ovaries are normal. There is no visible pathology in the uterus or ovaries. And if you can find the local cause could be anatomical anomaly or pathological anomaly in the uterus. The anatomical anomaly could be due to the developmental or congenital anomaly of the uterus, and pathological could be most common causes fibroids. When we go into the details of that, congenital anomalies either could be double uterus, and because then the bleeding surface is double, so that's why the bleeding is more. And other common factors are fibroids. You know from my last lecture, fibroids are 3 types: subserous, intramural, and submucous. Most common cause of fibroids which causes heavy menstrual bleeding, that is submucous fibroids, and sometimes intramural fibroids also cause this. Then another problem, a type of adenomyosis, which is really endometrial tissue growing in the myometrium. We call it adenomyosis. And that causes enlargement of the uterus, enlargement of the surface area to bleed. So that is also another cause. And as I said just now, fibroid could be submucous, it means fibroid polyp. But there are two or three other types of polypi in the uterus. It could be retained placental or placental polyp, mucous polyp, or malignant polyp. These are four types of polypi in the uterus. Then there may not be any anomaly of anatomical anomaly, but there may be endometrial hyperplasia. And that hyperplasia means thick endometrium. There are various types of hyperplasia. I would not go into details of that today. But in addition to hyperplasia, there could be malignancy of the endometrium or carcinoma. And last of all, a foreign body in the uterus can also cause uh, heavy menstrual bleeding. The commonest foreign body in the uterus these days is intrauterine contraceptive device. So these are the local causes in the uterus which could cause heavy menstrual bleeding. Those are the common causes. But there are other causes as well, as I mentioned earlier. That could be pelvic inflammatory disease, which causes congestion in the pelvis, or even a chronic infection in the endometrium, like chronic endometritis. TB endometritis normally causes amenorrhea, absence of menstruation. Tuberculous endometritis is one of the causes in Pakistan of amenorrhea, absence of menstruation. But in early stages of tuberculous endometritis, because of the congestion, there could be menorrhagia or heavy menstrual bleeding. The other causes in the ovaries are hormone-producing tumors of the ovary will disturb the cycle and may prolong the bleeding and cause heavy menstrual bleeding. And similarly, other tumors may cause local congestion, pressure on the veins if they are large, and then there could be heavy menstrual bleeding. So if there is some disturbance in the pituitary, adenoma or hyperplasia of pituitary, they can disturb the menstrual cycle. You know that menstrual cycle is regulated by gonadotropins produced by pituitary, anterior pituitary, FSH, LH, and prolactin. And uh, the disturbance of this will disturb the cycle and may lead to prolonged menstruation or abnormal cycle and leading to abnormal duration of bleeding. And similarly, if there's disturbance of gonadotropins, then they can cause ovulatory disturbance. Ovulation still may be there, but heavy menstruation, or anovulatory, and that could be this two different types of disturbances because of the disturbed production of gonadotropins. Other systemic causes could be any bleeding disease of the patient. If she suffers from clotting defect, then obviously during menstruation there'll be more bleeding. And sometimes some drugs, blood thinners, and anticoagulants if taken by the patient, they can cause bleeding. And there's sex hormones given from outside, they can disturb the cycle and cause this kind of. After the causes, incident. It is generally related to age and parity. This is important slide from clinical management of the patient. That heavy menstruation, we have made a long list of causes, but generally those causes, they show up or they cause the problem in certain ages and in certain parity patients. Immediately after menarche, it is quite common to have erratic hormone production from pituitary. So, disturbed cycles. And mother might bring her young teenager daughter to you that the bleeding is irregular or heavy. It is generally because of disturbed cycle of the pituitary. And similarly, the bleeding may be due to in young age disturbance in the endometrium level, response of the endometrium to the hormones, and that could be irregular ripening of the endometrium or irregular shedding of the endometrium. These days, PCO, polycystic disease of the ovary, is very common in Pakistan and India. Nearly 40% women are young girls. They suffer from PCO, but PCO doesn't necessarily mean PCOS syndrome. Polycystic ovaries are when there are only multiple cysts in the ovary, no other clinical features. But when the clinical features appear, it becomes a syndrome, polycystic ovarian syndrome. So PCO is very common, 40%. And then in some women, it may cause PCO symptoms, which are irregularity of menstruation, overweight, and ovulation, difficulty in conception, and hirsutism. These are four, either all four may be present in PCOS or any one or two of them may be present. So that is another common cause of heavy menstrual bleeding. And of course, I have already told you, congenitally double uterus that has larger surface area. Yeah. So all these four things, they show up in young girls. Yeah, it's immediately after menarche. Erratic hormone production from the pituitary and some problem with the endometrium, irregular ripening or shedding, and PCOS and congenital uterine anomalies. They are the in young teenager common causes. But similarly, just before menopause, we see a lot of heavy menstrual bleeding. You know, I always used to tell my patients that when a train takes off from a station, initial jerks are there before it gets to full speed. And similarly, when it comes to stopping, there are few jerks before it comes to standstill. So exactly like that, immediately after menarche, there are few jerks, irregular heavy menstrual bleeding, and similarly, just before menopause, there may be similarly. Generally speaking, in those patients who just before menarche come to you, that there's again disturbance of hormones, but we must not forget there could be local malignancy or endometrial hyperplasia. So these two causes we must remember in the later age group or just before menopause. In childbearing age, local pathology in the uterus is most common. Uh, it could be, as I said, fibroid, adenomyosis, and or a polyp in the uterus. Those four types of polypi which I named earlier. And of course, we must not forget malignancy can be seen in a later age group in early 40s. That could be that of cervix or endometrium. When it comes to see the bleeding pattern, there is no fixed pattern. We are today talking only about heavy amount of bleeding, irrespective of the regular cycle or irregular cycle. And mm, the, as I said earlier, the bleeding could be with regular cycle or irregular cycle. When uh, we look at this list, the fibroids, PID, and ovulatory disturbance, and other bleeding disease, in them the cycle will be regular every 28 days or within that physiological normal range. But the other causes, irregular cycle will be there. Like those are common, like organic anomalies of the genital tract, polypi, malignancy, and anomaly. In such patients, the cycle will be disturbed. When a patient comes to you complains of heavy menstrual bleeding, how to make a diagnosis? Obviously, first we'll take a detailed history. How long the patient has been bleeding, and obviously history includes age and parity of the patient and duration of bleeding or amount of bleeding. It's difficult to assess amount of bleeding. Generally, uh, well, scientifically speaking, all the sanitary pads must be weighed before they are applied, then after they are removed, and their weight will tell how much blood has been accumulated on those pads. But it's not socially possible. So we generally ask how many pads the patient used before this problem started, and now how many she used. If there's abnormal increase in number of pads, then obviously we'll accept her complaint as heavy menstrual bleeding. But some patients are fussy. They would change the sanitary pad even with a drop of blood or spot on that. And so in such patients, the number of pads will not give you the correct picture. And so there we have to investigate further, not only counting on the history of pads, we'll uh, ask other details of the medical history, social history, all the aspects of that, then examine physically. Most common sign of heavy menstrual bleeding is patient will look anemic, she'll look pale, anemia will be visible. When you look at the conjunctiva tongue, they look pale. And so that correlates with her complaints. If she looks pink enough, then possibly we need to do her hemoglobin estimation to confirm whether she is really bleeding or not. And after this general examination of anemia, we do local examination. And as I told you, locally, the common causes can be identified on physical examination. And of course, if the patient has been bleeding heavily, the most important investigation which will confirm the diagnosis is hemoglobin. The patient will always be anemic. Depending upon duration and amount of bleeding, anemia could be very severe. The hemoglobin could be easily less than 10, maybe 4, 5 grams only, which is very severe anemia. And local pathology can be picked up by ultrasound scan. And we normally do these days, instead of pelvic examination, ultrasound scan, because pelvic examination is a very private examination. And generally, patients are hesitant for that, even by a lay doctor. So ultrasound scan is very useful, which will confirm the local pathology or normality of the local organs. Well, if you suspect there is a polyp or there is abnormality in the uterine cavity, you can do DNC. Better is hysteroscopy, because these days office hysteroscopy is available in most of the specialist office, and it can be looked at, which is uh, whereas by DNC, you can miss small polypi. You can miss the diagnosis. It's not 100%. It's 80% at best. So hysteroscopy is preferable than DNC. But if hysteroscopy is not available, DNC will do. And the other investigations are hormone profile, not necessary in every patient. Remember this. FSH, LH, prolactin is not necessary. Maybe they are important for infertile patients, but for the diagnosis of heavy menstrual bleeding, you don't have to do all the hormone profile. But remember, thyroid upset, particularly hypothyroidism, they are prone to have heavy menstruation. And similarly, hyperthyroid patient may not have, but they are anxious type of patients. They may come. So thyroid profile is required where you suspect dysfunction of the fibroids. Once you made the diagnosis, first make sure that you have made the correct diagnosis, confirm it, and exclude all other causes which could be in that long list which I have given you. And after you have confirmed the cause, most important is, top of the list is treat her anemia. Now, anemia is not the subject I'm going to talk about today, but remember, anemia, the best way of treating these patients is iron deficiency, because bleeding leads to iron deficiency anemia. But if the diagnosis is confirmed this is iron deficiency anemia due to bleeding, then the best route to give iron is oral route. But if there's non-compliance, either the patient doesn't take the iron, or she doesn't like the oral iron therapy because of some side effects, then iron could be given parenterally. But in case the patient has severe symptoms due to anemia, shortness of breath, congestive cardiac failure, things like that, then that anemia may need correction by transfusion. So anemia may be corrected preferably by oral iron, but where oral iron cannot be administered, either the patient refuses to take or there is non-compliance, then parenteral iron. Remember, very important, that the speed at which the recovery will take place by oral iron or parenteral iron is same. So by giving parenteral iron or intravenous iron therapy, you are not expediting or hastening the recovery of the patient. It's only when you give parenteral iron that you ensure iron is in the system, and the speed of recovery will be same. As I said, if the patient is symptomatic due to anemia, then blood transfusion may be considered. And in addition to giving iron, if there's incidental disease which is responsible for heavy menstrual bleeding, like bleeding disease, or taking drugs which are causing iatrogenic heavy menstrual bleeding, or thyroid, any other. So first thing is to treat that disease which is responsible for this. When it comes to medical treatment of heavy menstrual bleeding, normally after prescribing iron therapy for anemia, correction of anemia, hormone therapy is prescribed. Hormone therapy is useful because it regulates the cycle, and generally the duration of bleeding also is within normal limits. So bleeding amount is reduced. Most common route or prescription is oral contraceptive pill. Oral contraceptive pill has got estrogen and progesterone, and it's so convenient to take. One tablet every day for 21 days, and rest 7 days, usually placebo, maybe iron tablets or parasulfate tablets. So regularity is there, and with that, cycle becomes regular, and generally the bleeding is reduced now. So oral contraceptive, mind you, most important for our region. Oral contraceptive pill is generally marketed almost free or at a very low cost by the government. So the cost of treatment is also very low. So the most common prescription is oral contraceptive pill, which is available in your area or marketed by the government. Then, if the patient is not brought under control with oral contraceptive pill, you can give progestogens only. And the commonest progestogen which is marketed is, brand name is Primolute N. And this is the 5 milligram tablet you can prescribe. And these progestogens, Primolute N, is given to arrest bleeding as well. If the patient is bleeding heavily, her demand is first control my bleeding. To control that bleeding, you can give tablets 1 TDS or even more for 10 days or so. That generally will arrest the bleeding and it will come under control. But if the progesterone is prescribed only to regulate the cycle, because oral contraceptive has estrogens as well, progestogens and estrogen. For some reason, you don't want to prescribe estrogen, then progestogens can be given in second half of the cycle for 10 to 12 days or 14 days maximum. One DOD, one tablet a day, or one BD, or one twice a day, and that will regulate the cycle. The third way of prescribing progesterone, right from day one, you give progestogens only for 21 days. That will also be necessary. But as I said, this is required where you don't want to give estrogens to the patient for some contraindication. Sometimes oral tablets takes longer time to be absorbed and digested, and you need immediate. Uh, so you can give injectable progestogens as well, and the other ways to give GnRH analog injectable once a month that will suppress the pituitary, stop hormone production by the pituitary. So the cycle will be stopped and the bleeding will also stop with that. These days, progestogens are prescribed uh, as quoted on intrauterine contraceptive device. You can see the picture. And that is known as Mirena. You can insert Mirena into the uterine cavity and progesterone will be absorbed locally and will act locally and reduce the amount of bleeding. So you can prescribe hormones either in the form of oral contraceptive pill or progestogens in various regimes. You can prescribe for 21 days, only for 14 days, or only by injection. And last of all, you can suppress production of pituitary hormones by giving GnRH analogs once a month. And if the patient comes to you not bleeding at the moment, you can use Mirena by local insertion and hoping it will control the bleeding. I've already told you oral contraceptive pill, and uh, sometimes the pill, if the patient is tolerant, can be given in double dose, but generally single dose is good enough. Other than estrogen and progesterone, you can prescribe androgens. Danazol is the common preparation which is available. These androgens, they have to be given continuously over prolonged period, and they will suppress the production of hormones, so stop the bleeding. So bleeding, if you desire to stop bleeding for months, 2 months, 3 months, 6 months, then danazol is prescribed. And if the bleeding is active at the moment, then prostaglandin synthetase inhibitors, they can be prescribed to reduce the bleeding. Similarly, antifibrolytic agents like transamine, they can be prescribed for 2 to 3 days to reduce the bleeding. Or you can tell your patient, if the patient bleeding is cyclical, that during each menstrual cycle, she can take transamine tablets, 1 TDS for 3 to 4 days, which will help to reduce the bleeding during menstruation. If the drugs don't work, then you have to resort to some surgery. And the common surgery, if the childbearing is complete, is endometrial ablative procedures. And unfortunately, they are not 100% successful. 10% of the patients who had ablative procedure will return with bleeding or further procedure. And so it is not universally popular method of treating these patients. The other method is uterine artery embolization. You can block the supply of blood to the uterus, and that will reduce the bleeding. This is intervention which is carried out by radiologists, and it's become popular. But remember, when we do uterine artery embolization, the maybe blood supply to the ovaries will also reduce. So early menopause is one of the complications. So in those patients who desire fertility or who don't want early menopause, uterine artery embolization is not the best treatment. If, as I said, commonest cause of heavy menstruation are the fibroids, and particularly submucous fibroids or fibroid polyp or intramural fibroids. They may need myomectomy or removal of the fibroids and saving the uterus. Fibroids can be removed by laparoscopy, which is the most popular method these days, or conventional laparotomy. But remember, after myomectomy, the incidence of recurrence is 5 to 10% again. So myomectomy should be carried out only in those patients where they have not completed the family. They wish to produce children. So there we save the uterus, remove fibroids. And if there's a polypectomy can be carried out through hysteroscope, or if the family is complete, best method to deal with this is hysterectomy. Again, it could be carried out by laparoscopy or by conventional laparotomy, and sometimes from the vaginal tract or vaginal hysterectomy as well. So if I summarize the treatment, correct, most important, top of the list, correct anemia by giving iron by any route, and preferably oral route. And then make sure that you made the correct diagnosis, because this heavy menstrual bleeding is caused by so many factors, so many reasons. And when you find the cause, treat the cause. But if no cause is found, then the best method is either OCP or hormones, progestogens, and or insertion of Mirena. And I would say not so commonly endometrial ablation or hysterectomy. Remember these, that first of all, anemia has to be corrected. Then make sure you made the right diagnosis and treat the disease as you made the diagnosis. But if nothing is found, no abnormality, that uterus, ovaries, everything is normal, then hormonal treatment can be prescribed, including Mirena. In those patients who have completed the family and they don't want to put up with this, then hysterectomy can also be carried out. There's a small sort of chart which I have prepared. I might have borrowed from a book, and just to simplify treatment, that if the patient under 20 comes to you, then bleeding is severe and non-responsive, then always, because the bleeding can recur, they need hormonal treatment. And if the age is between 20 and 39, then first try to defer the treatment. But if the bleeding persists, then DNC and hysteroscopy must be carried out to confirm the diagnosis. And when a patient comes into 40s or later age group, then again temporary treatment. But remember, malignancy could be there, hyperplasia or carcinoma, cervix and endometrium. So in such patients, hysterectomy is never performed under 20, and in between 20 and 39, rarely it is carried out, mostly hormonal treatment. And in to late 40s, are close to menopause, then the hysterectomy may be the first choice of treatment. Thank you very much. Hello. Uh, I have prepared, not I have prepared, my colleague, Dr. Mariam Iqbal, has prepared 10 MCQs and 5 SCQs for you related to this subject. Please go through because you will find answers in the back. And if you repeat or revise them, it will help you to pass your examination. And please don't forget giving feedback or suggestions how can I improve the next lecture. Thanks a lot.